Okay, there we go. How are you, people? 8 o'clock on the dot, 3 weeks in a row. Fantastic. The new me. Welcome to episode 43 of the Sports Therapy Association podcast. I always say really looking forward to tonight. I'm really looking forward to tonight. Really am. But I just say it every week. So, and if you've watched this for a while, you understand why I'm excited, because the guests have just been, it's just fantastic. And tonight's not going to be any exception at all. Really interesting topic. We are going to be talking about shockwave therapy, which I'm really excited about for so many reasons, which we will get into. But before we do that, if you're listening on YouTube, which you can do, live. If you don't want to go to Facebook, that's fine. Watch us on YouTube. You can still comment. Otherwise, you can join us live in the Sports Therapy Association Facebook page, which is open to anyone. You don't have to be a member to come along. And if you do come along live, which we encourage you to do so, then you can network, you can say hi, I can bring your comments and questions up on screen like I'm doing now on the video. So hey Mark, hey Tom, hey Harry Chambers. So it's a great opportunity to network, and like I say, so proud we get 50, 60, 70, 75 I think is the top so far, people live giving up their time for Thursday night. So it's beautiful to see so many people getting together and giving up their time. But of course, some of you will be listening on the podcast, which is an option as well. If you don't want to listen live, if that doesn't work for you, if it's a time difference or something, then that's no problem. You can find us on all good podcast players. You can also catch up with the videos if you want to see the visuals of the actual guests and what they look like behind the voices of reason. Then you can find us on YouTube. All the videos are uploaded there. And like I say, if you are a fan of the podcast, then do please do us the favor of leaving a review and a rating. It's all free. And all we do is we do this to put out the good word. It really is altruism at its best, I promise you. As is the Sports Therapy Association. It's a non-profit organization, and it's just helping therapists, supporting therapists. So in payment, what you can do, the nicest thing you can do is help us spread the word by leaving a review and rating on iTunes. If you're using Android, and if you're using iPhone, it takes 30 seconds. You just go to your app and it'll allow you to leave us 5 stars, which obviously is what you're going to leave, and a little comment. So do please try and do that if you can't. I think we're up to about 15 ratings, which, considering we get about 1,700 downloads last week, the math doesn't quite work. What's going on? It's a bit of give and take, so it'd be great if we could bump that up a little bit. Talking of the STA, you haven't got to be a member to watch this, obviously, but hopefully it'll give you an insight into what the Sports Therapy Association is all about. For people who are members or just interested in being members, I should say, we are doing a lockdown special membership now, because we appreciate more than anyone that people are falling on hard times. So if you are interested in being a member, for students, it's literally £1 a month for 2 months. Which I just can't believe I'm saying, but that's what it is. And if it's full membership you need because you're not a student, then it's £10 a month for 2 months, just to help you save the pennies whilst you're checking out what we're about. And then after those 2 months, even when it goes up to normal prices, you can see on the screen if you're watching the live show, for students, it goes to £35 a month. And for qualified therapists, it goes up to £60 a month, which I challenge you really to try and find anything both cheaper and of better quality, to tell you the truth. But then I'm biased, which is quite a nice segue into what we're going to do tonight. But we won't go there yet. So that's all details can be found at the sta.co.uk. So check out the website, which is looking very plush at the moment, I must say. It's all being redone and vamped up, and I'm loving that. So do go, even if you're a member, go out and check out the website. And as always, let us know what you think of it, because it's for you. Thanks last week to everybody who came along and everyone who's downloaded the show with the fantastic Jamie Johnston. Really such a great hour, such a great bloke, and a real pioneer, current pioneer in spreading the good word of kind of evidence-informed massage and manual therapy. Really so well listening to. It's everything I want this podcast to be, as in helping therapists who have heard on the touchlines that some of the things they've been taught and are still being taught might not be quite true. But it's scary. It's not nice hearing that something you've done or paid thousands of pounds for wasn't quite accurate. But it's the way it is for a lot of people. So rather than making you angry or making you feel like you're an imposter or chucking everything away. That's what we try and do. And that's what we're going to try and do tonight as well in every episode. Give you the chance to realize you're not chucking everything out with the bathwater. It's just tweaking a few things which will help you become a better therapist. It'll make you feel more proud of what you're doing. And ultimately, it's going to help your patients and clients as well. So thanks, Jamie, for forming part of that. Do check out Jamie's website. There's going to be courses coming up. There's courses running at the moment, and hand on heart, recommend them. Okay, so do have a little look at the Massage Therapist Development Center. Right then, tonight, we're going to fill the screen up shortly with fantastic people of knowledge, and Gary, and we are going to, sorry, Gary, that's a cheat. But we're going to be talking about shockwave therapy, which I'm really excited about because I know I'm going to learn a lot. I know that my biases mean I'm really dubious of any machines that go bing. It's just since my experiences with ultrasound and all that, everyone's got a story of the machine wasn't even on and the client's gone out the door and you go, oh, I didn't even switch it on. And maybe they come back saying it was brilliant last time. And it just makes you think, how much can we separate? Is it a crowbar separation, kind of traditional ultrasound from shockwave? Or is it just a way of making it sound more impressive by putting shock in there? We're going to find out. And I'm really thrilled to say that we've got two of the best people we could find to talk about it. Our very own Mike Grice, who you will have seen before, and also Ove Indergaard, which I've just said completely wrong, but that's going to happen all night, I can guarantee it. And we're going to bring up the big man, Gary himself as well. So keep the questions coming. If you haven't joined us live, then you're missing out, but try maybe next Tuesday. And that's it. So I'm going to now I'm going to hide the pictures for the moment and bring up the people in no particular order. Who have I left out? It was in no order. Oh, we're all here. Lovely. There you go. Hey, people.
Hi.
Evening.
There we go. Right. So we have in the screen, I mean, people who have joining us for the first time. I'll put the names on so you can see us and who we are. But for people listening to the podcast, then we've obviously got myself, Matt Phillips. I'm the host of the show. We've got Gary Benson, who's the founder of Sports Therapy Association. We've also got Mike Grice, who's been on episodes before, who a lot of you actually in the room, I'm sure, have done some of the courses stemming out of Birmingham. And also we have Ove Indergaard, who some of you I know have worked with as well in the past. And I'm very happy to have here tonight as well, joining us for the first time. So let's start off with Ove, who just has had no hassle at all joining us. So how's it going?
Good, thank you. Thanks for inviting me. It's a pleasure to be here.
Well, I mean, I'm not going to lie. When we knew we wanted to talk about this, you were the first man who was sent through our channels, both through Mike and other people. So I'm really glad that you've given up some of your time. And Mike, how are you? You all right?
I'm good, thanks. Yeah, good to see you again, mate.
Yeah. What's the news on before I forget, what's the news on the anatomy courses?
It's all kicking off.
I just opened up a can of dead worms.
No, it's great. It's Mondays. We're doing a live stream every Monday, basically following on from the chat that we had back in November time. So we're on episode 17, 18, something like that. So we've been going for about nearly 18 weeks. It's been really good.
Fantastic. And the possibility of the live cadaver workshops and that, is that?
I got confirmation last Friday that it's definitely going ahead in June. Yeah.
Oh, great news. Fantastic. And there was a list for that, wasn't there, which I'm sure people have been filling out. And that was going to be Kiel, is it still?
Yeah, Kiel University, yeah.
Fantastic. Well, there you go. And if people are still interested in that, I'm sure they can go to your website and have a look. We'll make sure the links are around anywhere, but we'll make sure it goes into the comments as well.
Great. Thank you.
Right. Big man, Gary, how are you?
Yeah, fine. Thanks, Matt. A few things, if I can, just before we start. Just a bit of a plug, really. For members, we have on a Wednesday morning, 11 o'clock to about 12 o'clock, we have a really informal Zoom coffee morning chat. There's no agenda. It's just ring up, join in and have a chat. And last week, it came up about vulnerability in the workplace for new therapists, for female therapists, and also it was brought up about male therapists and how do they protect themselves from, accusations of improper behaviour. And as a result of that, there's about 14 people joined a bit of a working group through Facebook, and we're producing a resource pack which will be made available to not just our members but to the wider industry. And there's been a lot of support for that in Gemma's physio support group. So that's hot off the press. So hopefully that'll come in the next few weeks. And then the other thing is that in the comment section on Facebook, which I can't see on Be Live, I posted a link to a list of the National Occupational Competency Standards which relate to electrotherapy. Just for the podcast, I'm just going to read them out briefly. They're not very long, but you have to take in context that these occupational competencies were consulted on in 2007 and 2008, introduced in 2009, and in theory expired 5 years later in 2014. So we are still just working to an outdated set of competencies, and Mike and I spoke at length about this last year. And hopefully tonight's chat will break down some of the mystery and propaganda behind the electrotherapy. So just briefly, Skills for Health, the Sector Skills Council, own the following National Occupational Competency Standards. D526 is apply magnetic therapies to client in a sport and activity context. D530 is apply electrical stimulation techniques to clients in a sport and activity context. D531 apply repair stimulator techniques to clients in sport and activity context. And then finally D532 apply advanced repair stimulator techniques to clients in sport and activity context. So there's nothing specific in there. There's nothing named apart from magnetic therapies. I'm fairly old. I'm 55. I can never remember magnetic therapies unless we're talking about what was around in the 1980s. So why that's in there, we don't know. But all of the other occupational competencies, it could be argued that the things that we're using today could fit nicely into those competencies, and that's what we're here to discuss.
Great, very useful. And all that information can be found on the Facebook page. Yeah. Brilliant. Okay. So a lot of information there, and definitely something we're going to tackle tonight, I'm sure. Any other housekeeping at all before we jump into it, Gary? Because once we get in there, we're never going to...
No, I mean, obviously with the step 2 of the roadmap to recovery, shall we call it, due on the 5th of April, we thought it would be a really good idea to get 3 or 4 of us together on the Tuesday the 6th and just have a look at what's been announced and sort of set out some of the roadmap to return to work. We are going to try and get our Welsh, Scottish and Northern Irish colleagues involved as well, so that we've got everybody's represented fairly. And it'll just be a question and answer really, because as usual, the finer detail doesn't usually come out until 48 to 72 hours after PM's announcement. So we're expecting towards the end of that week we'll be able to issue pretty comprehensive guidance, but fingers crossed that we are going back on the 12th. That's the earliest date possible. And I've seen that some people are starting to book people in. I think it's a little bit too early for that. By all means, start a provisional list, but let's not get caught out. And yes, I am aware that there are mobile massage therapists working, going into other people's home, claiming to be medical masseurs, etc. But we can't police that, that is just what it is. Let's us be professional. Let's us do things properly and be part of the solution to getting out of this this pandemic. And I had my first jab last week. I was a little bit man flu on the night, but I've recovered well, shall we say.
Yeah. Good words. Yeah, that's a great idea on that date. So have we got representatives from different parts of the country? Do you want people to kind of put their names forward if they're free?
I've got some ideas in my head, and I'll be contacting people over the next few days just to give them some preparation time. Fantastic.
Right. A question is already burning in the comments here. You can probably see on the side there, we need to tackle it straight away. Steve's brought it up, a few other people. Mike Grice, no hat.
Yeah, you're right.
It's also been supported and seconded by Becky. She said, I was thinking the same. What's going on? Let's just get that out of the way. If you listen to the podcast, and obviously you can't see, this is one of the reasons you need to kind of try and join us live. But basically, we're looking at Mike Grice without any headgear.
I didn't want to make it overtly pluggy, you know. So yeah, that's my usual kind of Monday attack. Yeah, sorry, this is my COVID hair at the moment. Yeah.
Okay, so apologies, Stevie and Becky, if that's been a bit of a shock, but yeah, he has got hair. Also, Peter, I apologize if I did suggest that there was live cadavers on the course. I can assure that all the cadavers are not live. But I'm sorry about that. It's not semantics at all. It's important to point out. But a few people already backed up about the anatomy courses. Catherine there. Hi, Catherine. How are you doing? She says, enjoy the Learn Anatomy online course. Yay to June. Stevie Barr is saying anatomy course is awesome. So Becky's saying, oh, I'll sign up for June now. It's confirmed. So a lot of love for the anatomy courses. If you missed that episode, I can't remember which one it is, but go to, did you say it was in November? Was it sometime, Mike?
Yeah.
That long ago? Amazing.
Yeah. I was unlucky number 13. I remember.
Well, seriously, that long ago? My gosh. Well, there it's there, and it's an amazing one, especially visually. So watch the video. There's some lovely videos and examples of anatomical variations and things which you can only really appreciate when you're up close and touching dead cadavers. So there we go. Right, we're going to start. Let's get rid of that. People, if you've got any questions, then fire them away. Oh, how do we start? How do we open this up? Okay, well, look, I'm going to put this out there first of all. To a certain extent, I'm going to be kind of the person who's bringing up the comments. I'm in my own little bubble probably, but one of the things I see against Shockwave, or one of the questions is, most of us, and again, this might be a generalization, aren't really using ultrasound anymore. There's been too many stories of whole football teams having it for the season. It wasn't even switched on. That might be kind of anecdotal and stuff, but so therefore, I think it's quite interesting to start to make a definition between traditional ultrasound and shockwave, i.e., is there much of a difference? What is the difference? Is that a fair way to start?
I think so. Seems like you brought it up.
I think it's an important one because I think that's one of the reasons people dismiss it.
It's a distinction to make, and both of them are sound waves. I think that's where the similarities end. They both use ultrasound gel to propagate the sound wave into the human tissue. But in terms of the difference of it, shock waves are around about 1,000 times more powerful than an ultrasound wave. And that's a huge difference. I guess the other thing to talk about as well is that there are two different kinds of shock waves, and they propagate differently in tissue because of how they're produced. So I don't know how many people know that there are two types, but one is radial and the other one is focused shockwaves. So radial shockwaves is basically probably the machines that most people have in their clinics, mostly due to cost, I guess. They have a ballistic bullet that flies up and down a shaft, which then creates a shockwave when it hits a metal transmitter, which then hits the skin, and then it kind of dissipates into the tissue that you're treating. Focused shockwave is different again. It has a different a wave that comes through. So often the two are separated as in radial pressure waves and focused shock waves, because a true shock wave has a characteristic of a rapid rise followed by a negative phase as well. So if you can imagine, a focused shock wave has a huge rise, stuff like that, which then drops down and becomes negative before it then peters out. And that happens in a fraction of a second. So that the average machine goes somewhere between 4 and 8 hertz. Okay. And it's really rapid and really powerful. So the difference between radial shockwave and focused shockwave is the power in the focused shockwave is around about 10 to 100 times more than a radial shockwave. So if a radial shockwave then has a curve that's more like that, then the focused shockwave has that spike. So there's a different characteristic between the two. So that's important to understand too. And the two different types have different uses and are better for certain things, which we'll hopefully talk about today as well, which is really, really important. But that's kind of where the similarity with the ultrasound is literally just a sound wave, but the power of it is just tremendously higher in the shockwave.
So when in studies, if people are we're going to bring up a few studies and things and screenshots, and we'll make sure there's probably, again, we'll create a little folder which people can look at the studies on. But when people see ESWT, as in extracorporeal shockwave therapy, is that referring to both those types, or?
Yeah, often both is categorized as extracorporeal shockwave therapy. Extracorporeal just means from the outside of the body.
Yeah.
Used because there are also intracorporeal shockwave.
So in the studies I've looked at, are they, if you look at the full text, do they differentiate between the radial and the focus then, or sometimes do they just regard them as the same?
Do you know what? There's such a discrepancy within the literature. Some of them discuss radial pressure waves. Some of them call it radial shockwave. Sometimes it's classified as a focus, and sometimes they don't even mention it, or they give a vague estimation, as in radial shockwave is measured in bar of pressure, and focus is measured in millijoules per millimeter squared. So they have a different measuring technique. So when you're reading a paper, often there'll be that's where you pick it up, whether it's radial or focus, if it hasn't been mentioned. And then sometimes sometimes the paper will say we used a pressure equivalent to so many millijoules, and there is a loose correlation between bars and millijoules, although that hasn't really been researched fully. It's an estimation of power that's usually used then. But yeah, it is very much a mixed bag, and as we do talk about research later on, there's lots of methodological issues involved with this research, and so you have to be really selective what you're reading. The difference between papers 15, 20 years ago to the last 5 years, for instance, there's differences there too, I think. And you just need to understand the technology a little bit before you discard the research or believe the research, as the case may be.
And there is definitely, it's one of those topics which is just made so difficult on social media because it has become very polarized, and people dismiss it completely, or people will love it and promise that it cures everything from period pains to headaches, and like they have done in the past. So it's tricky where therapists are going to look. So hopefully you two are going to sort that out tonight, because all they've got to do is kind of go onto one of your courses or look at your websites, and they'll get God's truth. Yeah.
Well, we try to guide people as best we can, and there are people that guide us in terms of where we need to start. There are places where you can safely start with shockwave and get some good results. There is what's called the International Society of Medical Shockwave Therapy, which is they lead both a scientific, both at a basic science kind of way, as well as the clinical research of it, and also guiding the teachings of shockwave. And they outline then more basic to more advanced to experimental conditions that shockwave therapy can be useful for. So what we do, like on our beginner courses, we focus mostly on tendinopathies. So tendinopathies is a good place. There's great evidence for a lot of the tendinopathies that we treat. And it's also one of the basic conditions that they mention in there, which are safe for most people to get started with. And the recommendations that they make in terms of basic to advanced to experimental is basically based on the amount of research that backs up those conditions too. So when you follow their guidelines, you know that what you need to teach people to start off with needs to be the tendinopathy stuff. And then everything else, as you get more advanced with things, you might want to, try on one of the harder conditions to treat, but they do need some clinical justification in there as well. It's not just a stick the machine on anything and blast away.
Brilliant.
Can I ask a question then, Ove, please? If you're running a course, how do you screen the person that may want to book onto your course? Because allied health professionals have all got a minimum standard of education. Members of the STA might be a sports massage therapist at level 3 with very little experience in the industry. It might be a career change, it might be a first job. We have soft tissue therapists who are remedially trained, and then we have degree graduates of sports rehabilitation and sports therapy. So is there a minimum standard of education? Because what I see when I go to all of the flashy conventions and expos is a salesman selling a machine on a lease basis, with the same salesman doing a 3-hour training course, to learn how to use it. And then I'm inundated with Facebook videos of people doing tendinopathy treatments with shockwave machinery. And my concern is that they haven't got the clinical experience or the clinical reasoning to know when to and when not to apply. So is there a minimum standard that you would expect in education for somebody booking onto your courses?
Yes, I teach for what's essentially Storts Medical in the UK. So I'm part of their teaching team, and they hire us in then to provide the education for them. What they basically ensure is that the people that come onto the courses have a minimal standard. So for us, it's allied health professionals that we kind of cover in our courses. I wouldn't say that we've never had somebody who is a sports therapist or a massage therapist on the courses, but when they then go to buy the machines, they need to prove that they are qualified to use it. So it's kind of...
Sorry, I was going to say, is there an assessment of competency then? Because we then move on to insurability. If I buy a machine and I do a course of training, am I assessed as being competent, so the insurance company will then cover me, or do some companies out there issue certificates of attendance or certificates of completion?
I think there's no assessment in our courses. Like I said, we cater mostly for medical and allied health professionals, and I guess that's where Mike comes in, where he's now looking into producing a course specifically for sports therapists so that they can get that qualification, which enables them to get the insurance. But that is not something that we're providing at the moment. What we do provide is different levels of courses now for both radial and focused training, so that people who have one machine or the other or both can then get both the basic and more advanced conditions covered in those training courses. But at any point in time, as an allied health professional, you are bound by your scope of practice, and it has to be covered within your scope of practice to use shockwave therapy. And certainly for most allied health professionals, that's the case. And the sports therapists obviously need to prove their competency, which I understand your question, but that's not something that Venn Healthcare that I teach for provide at the moment.
Okay.
Could I just say we do now?
Okay.
Newsflash.
I knew you were planning something.
Sorry, Eva. I kind of left you hanging on that one, but I finished writing it last week. So it's after our conversation, Gary, at the last Therapy Expo. So that was what, 2019. Where we were concerned about the 1-day courses and the certificate of attendance, and then being able to buy the kit. So I approached Storts because I got my machine from them, and I had a chat with Johnny, the guy who kind of heads up all of the, well, he was my contact basically. So I said, well, what do you do for sports therapists? How do we how do you assess them coming onto the course? And he had no idea that there were different levels, and why would he? There's no reason why he would. So I said, right, okay, well, I know about the levels, and I know where the gaps are, and so I've put together a course specifically to bridge the gap. And it's because I mean, Uwe mentions it on his course as well, like one of the contraindications is if you have some kind of neuropathy, because you can't feel a certain area of your body, and you wouldn't then apply an electrotherapy modality or a sound wave modality to that area because you can't feel it. So the person has to have the competency to be able to do a neurological assessment. So if you haven't had that as part of your training, then you shouldn't really be applying that machine, because you don't understand the implications of that particular pathology. So that and in the course that's the kind of thing that I've included in there to make sure that that ultimately that people are safe, and that's that was my kind of main remit really from then, was to bring everybody up to that standard of safety. And yes, they're assessed all the way on this course. So there's modules on tendinopathies and what tendinopathies actually are, what the best practice for managing tendinopathies are. There's then, and believe it or not, there's a bit of anatomy. So they know the bony landmarks and exactly where the tendons insert onto the body, because if you don't understand the anatomy, then you can't direct your treatment. So you need to have that level of knowledge as well. And then afterwards, there's an essay. So you have to do a critical analysis, and you also have to do a case study saying how you would treat someone from them contacting your clinic all the way through to the first treatment. So we've got a clear competency checklist to say, yep, this person knows how to use the machine. They know what the indications are for shockwave therapy, what Radial does, what Focus does, and they'll understand all that as well, and then be able to apply it and be assessed on it. So there you go.
Yeah, I suppose to anybody just joining in would think, oh, there's some joined up thinking going on here. But we've been talking about this for like you say, for nearly 2 years.
Yeah.
And it's taken, and I know COVID has had a massive impact on progression of education. But, we are addressing these things, in the background. We are doing things, not just ringing up and speaking to members. We are consulting, we are collaborating, and we are raising the standard, which I think what our particular industry needed.
Yeah, definitely. Yeah, I completely agree. Yeah, I think as Ove said, it wasn't really Ven's place. I mean, there's also a lot of other providers of shockwave devices, and it's not their place really to upskill our industry. It's up to us to do that, and they're selling machines. So and like I said, why should they understand the kind of intricacies of all the different levels of qualification? And it's difficult for us, let alone someone from outside of the industry. So we have to do it ourselves.
Yeah, and that's what we're doing, with regards to the occupational standards. We are consulting on those at the moment. We are looking at introducing occupational competencies that more mirror the current evidence-based and evidence-informed therapies that we're working in. So yeah, it's all progress, and the reason that we have people like Ove on here is to we're not here to give him the Spanish Inquisition, but we want to know how this is safe for our industry to use. We want to raise standards in our industry so we're taken more seriously, and the interprofessional relationships are the things that we're developing, and we're giving this access to the members so that they're better informed and they don't get taken in by just a salesman.
Mm-hmm. Yeah.
Brilliant. Well, look, this has answered about the next 12 questions, I think, in the comments. So it's pretty cool. I mean, Penny they're all great questions and everything I expected to be asked. Like, please, can you post where to train and advise on machinery? So there you go, Mike Grice. The next answer to the question is going to be, I did a level 1 course. So Sarah Jones did a course with Ven and Benoit. I was the only soft tissue therapist there and worried I was learning to use something that wasn't appropriate for level 5. They're also chuffing expensive machines. So we'll talk about the expense in a second, but there we go. It looks like there definitely is a gap to fill for some therapists. And what Gary raised earlier is, how do we know that you're not going to get kind of sold onto a course to buy a machine? Mike Grice. The next one here, we got Alex Rahim has mentioned another thing which we've covered. Recognizing the type of tendinopathy is one thing. Knowing that tendons may do need time and care around load and dose is another. So yeah, as Mike said, one of the modules will be a refresher, or indeed for some therapists, an introduction to tendinopathies and the different types and what you're going to take into consideration and looking at red flags. Alex did go on, for the benefit of people on the podcast who can't see the question. Alex did say, at what stage do you deem reasonable to apply a shockwave option? Are you okay with the application of shockwave without a loading strategy or bypassing it? And is shockwave used for all stages? So what about, I suppose it depends on the individual, but is it a case of let's do the kind of conservative loading protocol first, and then if that's not working, shockwave? Or are you at a stage now where you're confident that with some people it's a case of deciding one or the other or both at the same time? Or
I think the best answer for that is it depends. As always, it comes down to the individual case. In general, I would say, we need to get going with the loading program first, and give that several weeks to actually try to settle down. If you've got something that's relatively acute and new starting, you probably don't want to be putting the shockwave on straight away anyway. If it's any acute inflammation within the tendon, you definitely don't want shockwave on there. If it's been something, somebody comes to you with a history of, 18 months worth of Achilles pain, and they've tried, the YouTube, they've tried to Google their symptoms and do all the exercises and stuff like that. You would try probably a few weeks of a graded loading program that's designed for them at the right level for them. And if that starts to not go the right way, then you would add the shockwave into it. The general rule of thumb is kind of, 3 months worth of good rehab, and then you would start with some shockwave. If it doesn't work. So in a lot of the conditions like patellar tendinopathy, Achilles tendinopathy, there are a subsection of people who just don't get better with the loading program on their own. And that's where shockwave can come in and help out. So that it isn't necessarily a treatment that you would reach for the first time somebody comes in to see you. There are a couple of exceptions. Plantar fasciitis potentially would be one of those, and there is some evidence for that. But overall, it's a treatment that you would do for something that's a bit recalcitrant, that's a bit stubborn, or that's been there for a long time and they've tried everything. Quite often we get people in the clinic, they've had a couple of injections, they've tried the loading program, they've been to see another health practitioner, and for these people, we will just diagnose and start with the treatment straight away because they've been through the ringer already. But if like I said, if there's a new case, they've had the pain for a short period of time, the loading program is where it's at. You can't get stuff really better without the loading program. And I saw one of the other questions there as well, which talked about, do you shockwave alone? Do you shockwave and load? And that's a really, really important thing, because a lot of the research, but certainly in the early days, treated shockwave as a bit like an injection, where you had a dose of shockwave and then you had that maybe 3 times, or some studies even talk about it just once. And then they looked at before and after and saw, is there an effect of that? What we know, or what we kind of extrapolate from a lot of the animal research and the basic research that's been done on shockwave, is that shockwave is more like, the analogy is you're bringing the building materials to the building site. So what shockwave does is that it upregulates your fibroblasts, your osteoblasts, your tenocytes that actually start to produce new tissue. That's one part of what it does. The second part of what it does, it stimulates certain enzymes within your tissue, things like nitrous oxide, eNOS, vascular endothelial growth factor, all things that will then actually bring more blood flow into an area. So if you have something that's really chronic, that hasn't really completed its healing cycle, you can actually bring a new healing environment into the tissue. So when you're doing all these things, putting the loading program in there is essential, because if you have all these building materials in there, the tenocytes are firing up, you've got more blood flow coming into that tendon, and you've got a really nice environment for it to heal. We know that you can actually get some results from just doing that, but when you add the loading program, that's where the magic happens. That's when you start to see the biggest differences. The other effect that shockwave has is that it remodulates pain. And it does that through a couple of ways. One is the kind of the hyperstimulation and analgesia that you get immediately after the treatment. But there's also some modulation of CRGP, which is one of the kind of the things involved in creating a neurogenic inflammation within an area to sensitize the tissue, and also substance P. So it inhibits the substance P uptake, which again reduces pain. So when you then have a condition that's really, really difficult to load, sometimes it's a load capacity issue with tendons, and you have then a block of having pain there, doing a short course of shockwave therapy can actually get you past that block and actually enable you to do the exercises better. As in, what we tend to see when we start the shockwave is that the rehab is just much smoother. They tend to go from one stage to the next, and that, you know, you can't rush the body's response to these things. You still need to continue and do a complete loading program. It's not a kind of a shortcut, although sometimes it feels like that because the pain starts to go away quite rapidly. What you have to do then is ensure that you are doing the correct rehab to go along with the shockwave therapy. Make a bit of sense?
Yeah. I mean, yeah. Why is it? I'm interested because, I mean, I know it's tricky with studies, but one of the problems is, I mean, it is very expensive. Okay. And I guess that's because of the machinery you need to generate these much deeper kind of profound sound waves and things. But why is it? There are some studies which kind of support it with the greater trochanteric syndrome and that. I think there's some hamstring studies. But then there's other studies, which, I mean, those haven't been replicated yet. And there's others which show nothing. There's one systematic review which will go very low evidence. It's not evidence-based. Another one which will say, oh, we've had lots of it. What do you put that down to? Because it's not necessarily always poor study against good study. Sometimes equally good studies, it seems, when you look at them, find different results. So how would you explain that to somebody who's worried about putting quite a lot of expense into something, you know?
Yeah, it's a fair comment. I think there's a mixed bag in terms of the evidence. I briefly touched upon the difference between studies done in the early 2000s, in the 1990s, and what we're producing these days. Generally there's lots of different machines on the market, and there's no standard to how much power each machine puts out. So that there in itself, you have something that's really difficult to compare. So taking one study and comparing that to the other, if it's been used with two different machines, and they've used, you know, they've treated plantar fasciitis, for instance, but they've used different energy levels on two different machines as well. So say one used 1.5 bar and the other one used 5 bar. Huge difference in pressure. And one was an EMS device, and the other one was, you know, a focus device from Venn or from Storz. The results will be completely different. And then the other thing as well is, like, in the early days, and still certainly in some studies that we see, you have the effect of it's treated as an injection, a one-off treatment, and not necessarily having a standardized rehab program to go along with that. So there's just lots of discrepancies within the studies. So I think you need to really understand it. You have to delve a little bit deeper to understand what is quality and what's not quality. And that's really difficult for somebody who doesn't or hasn't learned about the technology. There's a great example. I was doing a little bit of research today just to see if there was any new studies that was coming out. And there was one study on focused shockwave for plantar fasciitis. Now, plantar fasciitis is probably the one condition that has the most amount of support for shockwave in the human body. And this study did 3 sessions over 3 weeks, and it had there was no difference over sham, which I was like, really? And then I looked into it deeper, and the pressure levels that they used was 0.02 millijoules, which is the second lowest setting on the machine, which is incredibly low. It's not even considered low shockwave, it's considered nano shockwaves. And when you then look at other studies that have looked into the optimal amount of dosage, you look at 0.1 to 0.2 millijoules per millimeter square second. So it's kind of a tenth of the energy that you would expect to have to get a physiological response in there. And then you kind of understand, okay, so that RCT, which looked really good on paper, and if you read the abstract, you show, oh, it doesn't work. But then you understand that the energy that's required to actually get a better response in the plantar fascia needs to be much higher. So it's really difficult to read this research unless you know the technology, which, sometimes, it's a bit of a bugbear, because I do understand it and I can read it and understand why things don't quite pan out. And sometimes, the studies are just ambiguous. There are areas within the body where there's some studies that say, yeah, this works really great, and for other things, it doesn't work so well. And so it isn't just all butterflies and rainbows. It's, if for certain conditions there are strong evidence, and for others, it's still, we need more evidence. We've got to figure out why it works for some tendons and not for others. Like the evidence for the lower limb is tremendous compared to the upper limb. If you look at rotator cuff problems, for instance, if it's calcific tendinopathy, it's got to run about a 90% success rate in bringing a good or a great outcome to those conditions, with 60% of them reabsorb the calcification, etc., which is tremendous. You then look at non-calcific rotator cuff, and the results are a bit, they're not so great. So it's then understanding why does it work for an Achilles tendinopathy as well as it does, and why doesn't it work for a rotator cuff problem? So it's kind of there's a lot more to learn, I guess, still, to get the most out of this technology. But what we can do is be a little bit research positive and learn what we can from it, and discard the stuff that doesn't work. So, when we already have research that's been around for a few years now in terms of the optimal intensity for treating the plantar fasciitis, it's kind of like almost a neglect to do a treatment which is a tenth of that power and expect the same result as previous studies have been there. So when you're replicating studies again, it's kind of a bit like, why did you even bother doing that?
I've never had it. I mean, the advantage of this over ultrasound is, I think originally I read it was used to kind of break down gallstones or something. It's powerful stuff. I don't know whether that's an exaggeration, but there's no doubt that is strong enough to disrupt tissue. But is it painful, or does that depend on the type you have? Is this a problem where I've read that it can be quite painful and you're told to put up with it? Doesn't that contradict with some of the other theories we've had? I've never had it, so I'm just asking.
Yeah, no, it's great questions. The background from Shockwave is through lithotripsy, which is a big medical machine which breaks down kidney stones, and having that is reasonably uncomfortable. They use a really high level pressure to be able to make that happen. Now, the machines that you have within your clinics, the Radial and the focus devices, are certainly not of the same power, for one. There are some studies, I can't even remember the reference because it's a really old one, but they looked at how many bar pressure you would need to actually create tissue damage with it. And it's over 6 bar pressure. Like Ven, for instance, the machines stop at 5 bar. So even at 5 bar, you wouldn't be able to create the amount of energy needed to do that. So it's been shown to be safe across conditions in terms of the very few side effects to the treatment. A little bit of skin reddening, a bit of pain during treatment is a common side effect. But what you need to do is that you need to then modulate how much power you use. So you want to create a stimulation, but you don't want to create too much of stimulation. You don't want the patient gripping the bed, biting down on a piece of leather to have the most amount of energy in there. The question I get from patients often is that, if you put the machine up higher, will that make my pain go away quicker? And it isn't the case. We're trying to stimulate some biology here. We're trying to stimulate some biological processes that's going to help that tissue heal. So we don't necessarily need the highest level. And there are research coming out, and probably most recently, I guess, where they look at using the lower level of energy to stimulate healing. So certainly for skin conditions and stuff like that, they use very low pressures and it still creates an effect. But in terms of the kind of most of the tendinopathies and stuff, it's medium pressure. But we're looking for somewhere like, 3-4 out of 10 is an optimal kind of pressure, something that you can lay there, you can relax and breathe, not hold your breath, but you can take a little bit of discomfort. Probably no worse than you sticking a knuckle into somebody's piriformis or something like that. That's probably more painful, I would think.
Ove, can I just ask then, you've got the variable of the pressure on the machine.
Yeah.
What about the variable of time? Can you achieve, probably a bad word, tissue damage by applying shockwave for too long a time period?
That's an interesting question. You normally go by dosage. Mm-hmm. So you would go by dosage. So the average tendinopathy, for instance, would receive about 2,000 pulses. like I said, there hasn't been any research studies that have mentioned any side effects of that nature. There was a study, I've got it written down here somewhere. It was a study of 2,800 cases, I think, of 2,800 heels, and there was only 250 cases where they actually reported some reddening of the skin, let alone anything else. And that's usually done at a relatively high bar pressure if you use shockwave, so often like 3 bar, maybe 2.5 to 3 bar for a plantar fasciitis, and for focus, 0.1 to 0.25 millijoules. So yeah, there just isn't any reports in the literature, if you like, about tissue damage.
Yeah. Matt, there was because of there's lots of questions coming in. I'm just scrolling back to one. So Steve Kirby, 2023, could shockwave therapy aid the function and restoration of hypertonic deep muscles such as the lumbar multifidus? So would anybody care to answer that? Is it appropriate treatment in the first instance?
Well, I'm happy to answer that one.
It's well, for me, I think you may get some pain relief in an area whether you can assess whether a muscle's hypertonic, and then the changes afterwards. I wouldn't know. Over to you, Uwe.
Well, there's quite a bit of research on spasticity and use of radial shockwave in treating spasticity in neurological clients. And they achieve great results in terms of reducing tone in muscle. So in terms of then MSK use, the places where I've used that successfully personally has been when people have had the previous disc issues and they've got really hypertonic low back muscles. And for 1 session or 2 sessions, we will just go over with the radial, detonize that muscle, and then start to re-educate that movement segment. So it does work in detonizing muscles, but at the same time, it's not a massage therapy gun.
Mm-hmm. Yeah.
How do you measure it then? When the research is done, do they measure it through imaging? Do they measure it through,
They use loads of different measurements. In terms of tendinopathies, like if you take the Achilles, it's often the Visa A questionnaires that gets used, the standard stuff that you use for that. For tennis elbow, it's a combination of grip strength to VAS scores to dash functional questionnaires and things like that. So every research study uses slightly different depending on what the area is, but they try to standardize it. Certainly the newer studies are much better at that, and you recognize the stuff that they're using to measure it. And it's not just VAS scores. There are other things too. The one thing that we can say, there might be a few question marks in terms of knowing exactly how the shockwave works still, although we have some idea of how it works through mechanotransduction and the biological stimulation. We do know that it works with pain and it improves function, and that comes down from the research that's been done on it and the outcome measures that have been used.
Where will it end? Electrotherapy, you mentioned that shockwave was born from some hospital-based machinery. We're starting to talk about lasers now. How far can technology go to make the human body better?
It's a good one. Laser's been around for since the 1960s, I think. It's an old technology now. I think the same with shockwave. Shockwave has been around since 1980. It's 40 years old. It's not new technology. I think it's becoming more popular because we're looking at options. I think, is it the fact that some of the conventional treatments that we're doing aren't really creating a difference for those people who are stubborn to treat? And are we then looking for other options? I don't know. But certainly, I don't know where it's going to end up. I think there are some exciting developments in stem cell therapy and things like that, which are coming up in the next few years, I think, which will be interesting. But in terms of electrotherapy, I'm not entirely sure.
You mentioned massage gun, right? But this is massage gun is on the same spectrum as all of this, because ultimately we're just talking about vibration, aren't we? It's the same as jacuzzi, it's the same as ultrasound. You say there's kind of the biology of it and mechanotransduction, but all we're really doing is just sending stronger vibrations through the body. There's not any new technology other than that. It's just we're figuring that because they're stronger, they're having more of an effect. But the actual effect of how that, it's the same as a machine gun, isn't it? A machine gun, that's slightly too vibrational, but a massage gun.
I think it comes down to the power of the vibrations and what is actually achievable. Whether you be able to treat a mid portion Achilles tendinopathy with a machine gun.
I said it now. And also might as well like to treat
with
it with
a massage gun or whatever.
Yeah.
I think it's debatable. I don't think you would actually create the power in there to do that. I don't have the answer to that one, but it seems plausible that there's a reason why ultrasound didn't work. It was underpowered, I think, and I think the difference in shockwave, and certainly for certain conditions, focused shockwave can be a game changer, even when radial shockwave has failed. Sorry, I think you got a question there.
Me?
Yeah,
I've got a quick question then. You mentioned ultrasound having failed. Okay, why is it that it's still so widely used? In multidiscipline clinics, I'm not going to name professions, but in multidiscipline clinics, why do we still go in there and are subjected to 7 or 9 minutes of ultrasound if the evidence is really that bad?
I don't have the answer for you there. Personally, I haven't used ultrasound for at least 15 years. We got taught it at university, but when the research comes out and shows that it has very little to no effect on conditions, you kind of just got to go, right, let's park that thing. Why some people still use it, I have no idea.
But in its day, ultrasound was what shockwave is now. Some people would argue that it's quite incredible that everybody dismisses the ultrasound and says, "Oh, that's rubbish." But shockwave, that's the latest thing.
Ultrasound was bigger. Ultrasound was bigger than shockwave because every single clinic had it. Relatively cheap to buy, and every single clinic had it back in the day.
That's why so many people used it. It was so accessible.
Shortwave and photophoresis and Faraday's and all these electrical stimulations and stuff like that, which gradually have just been kind of put to the side and realized that it doesn't actually make such a big difference, and other things make a bigger difference. I'm quite biased here. Why is shockwave better? I think shockwave is starting to prove through the evidence base that it has a role to play in treating stubborn musculoskeletal conditions. It's non-invasive. There's very few side effects to it, and therefore is an alternative to other more invasive things. So if you are faced with the prospect of conservative treatment has failed you, and you are now looking at a steroid injection or a PRP injection, or you're going in for surgery, then you have something that's much safer, much less invasive. And although we're going to touch on cost in a bit, it is an option there, which, the patients then can choose to have that option rather than being thrust upon by clinicians, I guess, what they need to do next. We have a lot of people that come and seek us out because they want that non-invasive option.
I think we're going to need a part 2 of this. Are you free next week? We're going to have to. I mean, literally, it's 8:58, and we've got so many questions. And I really want to devote quite a lot of time onto, right, if a clinician wants to actually invest in this, what are some of the ways of doing it, getting hold of the equipment, making sure they can do a course, finding out for them. But we just simply haven't got time to talk about that now because it's like 8:58. But we'll have to kind of try and, I think it's definitely worth a part 2. Because like you say, the evidence is both ways, and that, that means there's something in it. I mean, I just wanted to ask one question. How much of a factor is, and again, this is my bias coming over, but like the pain modulators, for example, how much of a factor, and you've obviously considered this, is the fact that it's a machine, it's expensive. The contextual effect has got to be huge, because we know that's the case when someone applies something which you can't really do yourself, even though in theory, maybe arguably you could do yourself. Is that something that you take into account? And when you look at the research, it could be just like that next new thing, and that's why people are jumping for it, and you were getting good results? You can say no if you want, just no.
No. I think well, I can talk you through my journey with it, but how I started with it, which is, relatively standard, looking at how people come across it on the courses that we run. I had quite a few stubborn tendinopathies, and I was looking around for what are the other options for treating these things. Back in the day when we first qualified, we used things like deep transverse friction massage and things like that, which can help some things still. Like if there are any connective tissue kind of issues there, but I needed something in my arsenal that would actually help my patients more. I was getting really frustrated with it, so I started looking around. I found shockwave therapy. I started reading the research, and the research, was showing me that there are a possibility for treating these really stubborn cases. I then went and spoke to experts, people who have been using these machines for a few years. I went to one of the basic courses, learned some more of the theory, got to handle the machine, got to really, see what it could do to problems. And then when I got the machine, I started using it, and I was pleasantly surprised of one, how easy it was to get the results in the research was talking about. And then, in the beginning, there is a little bit of a learning curve where you have to fine tune a little bit your skill in terms of when to apply it, who to apply it to. And that clinical decision making is something that you need to spend time learning. And it's not necessarily something that you will get from, your beginner's shockwave course either. And, having that responsibility over your clients then to conceptualize what you're actually giving them is important. And you mentioned it's the new big thing, and I would imagine that you could sell this to patients in a way where they will go, wow, this is really going to work for me, because it's expensive, it's the most advanced technology out there, all these things you can be told. And I think as a responsible clinician, you owe it to your patients to, tell them about the research, tell them about the possibilities. Like, you've had this problem for a little while now. What if we tried something different? This is Shockwave. This is what it's proposing to do. And within this amount of time, we're expecting to see these changes. And then you have a decision-making joint with the patient of, do you think this is a good idea? Is this something that you want to do? And then if they agree to go ahead with that, then, that's fine then, isn't it? And it's like, it's about patient preference a little bit too. We have to bring the patient in on the decision-making. It's not necessarily just about, we've got a new toy and we want to apply it to all our patients.
Look, we're going to have to do a part 2, which I think maybe would focus on, I mean, the reason I'm brought into it is because you two are talking. So, I mean, I'm a classic example. If you were my therapist, or going, yeah, I'll try it, because I have faith in you two, because I know you're both kind of evidence informed, and you're not salespeople. So, but I think it would be nice to do a part 2. There's already a few people asking about, right, if I want to make the investment, how do I do it? What's the path? Which machine? Do I have to do this? Do I have to do that? Details of the courses. So do you reckon that's something we could put together and do a part 2 of? We're not going to try and sell you the idea anymore. Here's a way of seeing if it's for you. Cool. A path to do it. Do you think that'd be cool?
Yeah.
Also, Mike's hardly said anything. I think.
I was going to say, because I've got the 2 machines as well, and over the last 2 years, I've implemented it in my clinic, and I could say about how I've done that and the effect it's had. I know some people have talked about adherence to treatment, and it's had a massive effect on that. Huge effect on adherence. And so there's loads of things kind of from my clinical experience that I could, from a sports therapy point of view, that I could bring across, no problem.
I think that'd be great. I think it'd be really interesting, and we could spread the word. People, I think about 58 of you tuned in today, and there'll be 1,000 or so listening to the podcast. So maybe we could even we could set up a little question thing about what would you like to know more of, and put some questions together for you guys. If you could come back at some point, that'd be great.
Yeah, sure.
Cool.
Mark, there's 2 ways we could do this then. We could either, have another web chat on it, or we could create you know, like you said, a survey to ask some questions, and we could invite people. We could do it over a Zoom call for people who wanted specific answers. We could do that quite easily. So if you want to comment in the comments for us, do you want another one of these sessions? I think it would be really valuable, you know, for the reasons you've already outlined. Or do you want to do it on a more personal level, one-to-one? Well, so a group sort of Zoom call. So just let us know which you'd prefer, and then we'll facilitate that for you.
Okay, and they're still just asking questions like we're just talking to nobody. Questions going down. Guys, it's 9:05 now. We're going to have to call it a day. It's soon by. It's the fastest episode I've ever. In the meantime, before we do a part 2, if people want some more information on what both of you guys do, where's the best place for them to find out? Do they contact you, or is it all available on your websites, or where can people look to either of you?
Movement therapy education for me. Yeah. So either on my website or Facebook group.
Okay. So movement, if you listen to the podcast, movement therapy education, how do they get to the website? Just put that in Google's the easiest way, isn't it?
Yeah. So mte.education, mte.education.
Okay. mte.education.
And actually my clinic website, you know, you can contact me off that. It's indergaardphysio.com.
Brilliant. Okay. And in terms of social media, if people want to follow you and see you kind of like what you're talking about, where's the best place for each of you? Where do you tend to hang out? Was it across the whole board?
Insta mostly.
Insta.
Yeah.
Fantastic. And for you, Mike?
Starting to get into Insta. Mine's mainly Facebook. Facebook is
okay. Facebook and Insta. Fantastic. Right, Gary, anything you want to end with or mention?
Well, if you want to follow me on social media,
don't.
No pressure.
Best to shout over the garden fence for you.
Yeah, well, Sarah Jones has just said happy with either as long as it's still available to non-STA members. So I think, judging by the comments here, let's do another one of these. You know, let's get together with timings, etc., and we can rearrange one of these then.
I think so. Especially go and tell you. I mean, this is a chance. I am skeptical and cynical, but it's because of the people maybe I've met in the past. But when you've got two people like this who you can guarantee are trying to challenge themselves and they're looking at, right, as science does, how could we say this doesn't work? Or what are the ways which disprove this? These two are all about it. So try to also encourage people who you know have dismissed it on social media. Just chuck it out. You know, just go, oh, it's all rubbish. Ultrasound doesn't work, so this doesn't work. Try and get them along as well, so we get some interesting questions, because I know that these two are very well equipped and they won't take offense, you know, to be challenged. So yeah, try and spread the word, and we'll make sure we put another one together.
Yeah,
right.
Definitely sharing this this podcast and web chat through your own platforms is a really good way of doing that. And yeah, definitely look forward to a session number 2.
Fantastic. Ove, thanks for giving up your time.
No, pleasure.
Brilliant. And Mike as well.
No worries. Thank you.
I feel like Mike hasn't said much this episode. It's like he's just sat there without his hat on. So apologies for that, but guaranteed next session, Mike will be back to his normal self. Maybe it's the hat. Maybe you do need to wear a hat.
Yeah, that's it. Yeah.
You lost your Samson's hair. It's been right, gang. Sorry about the late finish, but we will be back soon. Watch out, obviously, on social media and on the website, and we're back with a part 2 to answer all those other questions about how you do invest in this. Is it for you? Courses, types of machines, etc. We will get to it. Thank you very much, everybody. We'll see you next Tuesday. Take care. Bye-bye.
Cheers. Bye.
See you guys.